echo. Please note that we're filming today's echo session for educational purposes, so please mute your pagers and phones to minimize disruptions. CME and CEU is going to be provided for this event, so please see your email and website for details. Today's didactic, we're very excited to have Dr. Sean Tim Payne as our guest speaker. He's not really a guest because he's part of our palliative care specialty team. He's going to be presenting on palliative care and the role of communication skills. If you have any questions today about the didactic, you'll have the opportunity to ask them at the end of the session. Didactic session. Okay, Sean, take it away.
Sounds good. Can we advance? All right, so today we're going to be talking about palliative care and some fundamental communication skills that I think what I hope you will find is that we all actually use these in everyday life, not just in palliative care situations. And I hope also by the end of this talk, you'll have some new ammunition for those difficult domestic conversations, conversations with family members, even at the store when things aren't going well over on Black Friday. So with that, we'll go ahead and get started. So this is a conversation map the palliative care team developed to explore what the process of having a serious illness is like for a patient. It's also something reflective about palliative care where we are potentially a guide for the patient, someone who's been down this river before, but that every patient's journey, their experience is a little bit different. You know, their sources of support, the difficulties they may face, and some of the decision-making they may have to undergo are different. But there's some really universal things we can reflect on in conversations with patients. And these tools, these skills we're going to talk about today often are incredibly useful at the decision-making points, also in getting to know your patient better about what's important to them, what they're really hoping for. Just to remind everybody, palliative care is specialized medical care for people with serious illness. And we take that holistic approach, really looking at the mind, body, and spirit, and trying to provide relief from all the symptoms and stress of the serious illness, not just the physical symptoms, but the emotional distress, the spiritual distress. And, you know, working as a team to provide this support to anybody at any stage of a serious illness. And we really think a lot about our communication to get at what those sources of suffering are. And we'll talk about that next. So before we talk about behaviors to cultivate, first we're going to talk about some behaviors to avoid. So the first behavior to avoid is blocking. This is probably the most blatant thing that we've probably all done. I certainly do it when my 3-year-old children are asking me questions or pushing me about something that I just don't have time to talk about, and I just tell them that. I'm sorry, I don't have time to answer your question right now, or I change the subject to something else. I literally ignore them and or change the subject. Changing the subject is probably the most common thing we see providers do, or minimizing. So, for example, a patient says, you know, what does this mean for me? Or am I dying? And someone says, well, we have a lot to talk about in regards to your treatment today. That would be an example of blocking. And the whole thing is that, you know, what we talk about in palliative care, what we talk about when we talk about people who have serious illness or perhaps a poor prognosis, it's not fun to talk about. It's really difficult. It's emotionally challenging. It's often inefficient conversation, so it requires a lot of conversation to work through it appropriately. And the path of least resistance is avoidance. So these behaviors to avoid, there's a common sort of theme, and that a lot of it allows us to avoid talking about the more emotional matters at play. The second strategy that we see all the time is lecturing. You know, part of this, I think one thing we always have to remember in palliative care is, you know, we're, as a supportive team, we're not always the ones delivering the information or the medical plan. We're often following up, filling in the gaps. But for when you do have to deliver the medical plan or a medical update and be the first to do that, there's a lot on your mind. You're trying to deliver a lot of information. And the response when you're delivering a lot of information without a pause, without a check-in for, you know, how's this sitting with you? Are you understanding what I'm saying? Is often silence. And then silence is furthermore interpreted as understanding and, okay, this is good. And that one-way conversation is somewhat comfortable for the person, you know, jabbering on and on and on and on, but it doesn't lead to good communication. And in fact, it can avoid talking about the meaning of this information that you're providing, the impact it might be having emotionally or on what's important to the patient. So you may be talking about the chemo, the radiation, all the imaging you're going to do, but to the patient, all they're thinking about is my kids at home, I'm going to have to come back to Anchorage, all the impacts it's having, but by lecturing, you may be missing out on that. The next one is collusion. I think this is one of the most common, and this is where both the patient and the provider, and when I say provider, I mean all of us, anyone interacting with patients, choose to kind of avoid things that might be the elephant in the room. So, oh, I just had a CT scan. The doctor didn't bring it up, so it must be good news. Meanwhile, the doctor is saying, oh, they didn't ask about the results of the CT scan, so we'll just talk about the plan instead and not talk about the significance. And it's not often that conscientious. It's usually sort of a subconscious avoidance of talking about difficult information, but this happens all the time. It also happens when there's lots of providers taking care of the same patient. So assuming that, oh, one of the other doctors or one of the other providers already had that conversation. The patient, again, assumes, or doesn't really want to talk about it themselves. So no one tells the patient or the family what's actually going on because everyone kind of wants to avoid having that difficult conversation and assumes that other people have had it as well. And the last one's premature reassurance. So again, it's a little bit like blocking. It's often minimizing the concerns of a family, or being uncomfortable with how bleak delivering a bad piece of information can make everyone in the room feel. So this is common where maybe you've just told them that you have an incurable cancer. And instead of emotionally processing, you immediately go to, but don't worry, we have lots of treatment for that. And you move right into how we're going to take care of you, which is a little bit misleading because the information you just delivered is this person's likely to die from their cancer. And so the conversation that might be most valuable is to explore what that means, what a big impact that is, how difficult that is, and then move on to the plan. Premature reassurance also happens a lot in rural areas where patients start to bring up concerns that they may have been real scared about. And there is definitely maybe nothing to be worried about from the assessment, but to that patient, to bring this up, this could be incredibly stressful, incredibly worrisome. And what we're missing there is meeting the patient and family where they're at emotionally. This is common in the pediatric setting too. So for example, a mom who has children and it's their first time getting their shots or blood drawn, that mother may have had experience herself getting her blood drawn, but to see your child go through something different, or maybe they're having some conscious sedation for ingrown toenail or something, but going through that process could be incredibly scary, and the provider might say, oh, it's no big deal, like we got this is routine. It's kind of acknowledging things that are routine to us, and when we work with seriously ill patients all the time, a lot feels routine. But for families, it's not routine. This may be the only time ever that something like this has happened. And it's really trying to understand their experience, not our experience of it. So now we'll move on to some behaviors to cultivate. Next slide. So we'll talk about a few. We're going to talk about ask, tell, ask, which is really kind of the standard framework for how we have all serious illness conversations. Tell me more is a great back pocket tool. And then how to respond to difficult emotions using the mnemonic of NERD. So the first behavior to cultivate is ask, tell, ask. And that's exactly what it sounds like. So when we see that we are making a plan to see a patient and we have an agenda, we have things we want to talk to them about, we have reasons we want to go see them, prior to jumping into all the things that we want to do and the things that we want to say, we start by asking them, where are you at with your care? What have you heard? How do you understand your situation? So ask is really, there's a lot of asks. It's really get to understand what they understand about what's happening today, what are their goals for the meeting. It's switching it from a provider-centered meeting to a patient and family-centered meeting. It also, if you're going to be delivering with the tell really difficult information, you also use this ask to ask permission. I have some serious news or some difficult news I want to talk about with you today. Would it be okay to talk about that with you now? Or would there be other people you'd like to be here for that? So you're asking permission. Some patients, have different information sharing preferences. So rather than coming into the meeting and blitzing right ahead to that, I'm here to tell you today I'm sorry that you have incurable cancer. Oh my gosh, I wasn't prepared for that, and this is really traumatic, as opposed to, saying, would it be okay if I share with you the results of the CT scan now? Kind of sets the tone, prepares things. So then the tell part. The tell is delivering the news. And specifically today we'll talk about delivering difficult news because it's a little bit harder. But this is useful even if you're talking about, let's say you're just doing a CBC for red blood cell count and you want to tell someone how their anemia is doing. Again, preparing them. I want to talk to you about that. What do you understand about why we're doing, the purpose of this test and what we're here to find out today? And then you can tell them those results. In the telling, the key is to do this on the patient's level, on a digestible level, and in digestible chunks. So rather than go on the long lecture with an extensive explanation of not only what the result is, but what it means from your point of view, do it in bits and pieces. Pause, ask, see how they're doing with their understanding. We're particularly bad about this in medicine. We speak to each other efficiently and rapidly using a lot of lingo, a lot of terminology. It's helpful to us, but it's not helpful to patients. And then in between the next ask, I really wish there was a pause. So ask, tell, pause, ask. I think if the delivery of the news is something of great importance or of grave news perhaps, giving a moment for impact, allowing things to settle in, getting an assessment of the room before moving on to the next ask. The last ask is really, getting an understanding of what they took away from what you told them, making sure that they appropriately heard what you said, that they're understanding the points you want, and then this whole process repeats and repeats. The thing that I would ask you guys to take away is to try and make all of your encounters a little more patient-centered. So just by starting with the first ask, I think everyone could do a better job about knowing what maybe the patient already knows all the news that you were even intending to tell them. So it's a great opportunity to be filled in that they already know a lot. But at the same time, you're allowing them to set the agenda, set the tone, and you'll find, I think, your conversations will be much more efficient and much more helpful to patients. Tell me more. This is kind of the jack of all trade of communication skills. I'll start off by describing it as kind of my safety valve. If I ever get into a really, really tricky conversation and a patient surprises me with a really difficult question or they're really upset about something and I'm on my heels and I'm just like, I'm not sure what I'm supposed to say in this. I've never been in this situation, and this happens to all of us where somebody just kind of surprises you. Kids definitely do this all the time. They just surprise you with a really insightful or challenging question. You don't have to have the answer. Instead, you can explore. And you can do that by just saying, tell me more. So it might be an emotional expression. So I'm just feeling really upset, and you have no idea why they're upset. So instead of avoiding that, you could just say, tell me more about that. It sounds simple, but it works really, really well. It lets the patient know that you're paying attention to their emotion, and it deepens your understanding of what's actually going on, because you could make an assumption about what they're upset about, but instead you ask them to tell you. And making an assumption can make you look pretty silly. So we shouldn't think that we just intuitively know all the emotional reactions of our patients. The other two levels of tell me more are really what is happening. So maybe they, tell me more about what you understand about your situation. That's kind of a backhanded way of asking for their illness understanding. They may want just explicit medical information. Another tell me more is, what does this mean to you? So, now that I've told you all of this, it's kind of that last ask in the ask, tell, ask. So tell me more about what this, how this will impact you now that you know this about your disease. So there's multiple levels of tell me more. And again, the dangers in making an assumption. Chris often tells this story about a patient in an oncology office. He has a terminal diagnosis of incurable cancer, and they hadn't really talked a lot about end-of-life planning. And they're finishing their appointment. They're making a follow-up for a month, and the patient goes, "Doc, how much time do I have?" And the doc was about to, oh my gosh, he wants to talk about end of life and preparing to deliver, prognosis and really get into the nitty gritty of what end of life is like. And instead the doc says, "No, tell me more." And he goes, "Yeah, because I've paid the meter outside and I really got to get out there. So how much time do I have?" And that happens pretty regularly actually in our lives. And it's, again, don't make assumptions. Really ask a little bit more. Not that it might not have been a good thing to have that conversation for that patient, but really the patient wasn't ready to have that, and the doc actually answered the real question the patient was asking. So really, really useful skill. I encourage you all to just try it out. Try it out. So next is responding to emotion. Again, this is something we all have to do every day, and I think as I go through these, you'll realize that there's a lot of things that we kind of do innately with this. The first two are naming and understanding. These are statements I think we use a lot with patients who are experiencing sadness, frustration, anger. The respecting and supporting statements, I think, are really nice additions, and you, as I go through them, something you could consider scripting for yourself with personal conversations. And then exploring is very much tell me more. So diving deeper, not assuming that you understand the whole scope of that emotion, but asking the patient to explain more about where it comes from, about who it's directed at, or what it's directed at, and diving a little bit deeper. So we'll go through piece by piece. So naming. So naming is as simple as it sounds. So let's say you come into the room, they're emergency department, you're a very frustrated patient, they're angry. You could start by just saying, "You seem really upset." Or if you're bold enough, you could say, "You seem angry." And sometimes that even enhances the emotion temporarily. So the patient might say, "Yeah, I'm angry," but they at least know that you're seeing them, and their emotion is what's most important in acknowledging. And you want to, it's kind of saying, "Tell me a little bit more about this because I see it. I see that you're upset, and I'm here to hear about that because I care." It often de-escalates difficult situations. Maybe you delivered really bad news, and the family's totally silent. You could say, "It seems like this came as a surprise," or "It seems like this is shocking," or "You seem sad." Whatever it is that you feel in the room, that you sometimes even feel in your own body, is sometimes reflective of what the patient and family are experiencing. And just by doing it, it really starts the conversation. It helps lower the temperature in the room. Understanding statements. So understanding statements is about normalizing that emotion. So, let's say a patient is telling you the story, how they're frustrated with their previous medical care. You could say, "I understand how frustrating that would be for you." Or let's say a family's going through something that's so difficult for them. You can use the negative version of this, which is, "I can't imagine how difficult this must be for you." You do have to use some care with this, because sometimes in your statement of understanding, you're saying that you do understand that person's experience. And you very much don't. You're doing your best to put yourself in their shoes, and they may take a little affront to that. They might actually say, "You have no idea what I'm going through." And so you might find it a little bit safer to say, "I couldn't imagine," or "I can't possibly understand how difficult this must be for you." And it's really helpful. Those are really helpful statements, because you're saying it's totally reasonable that you're incredibly upset in one way or another, whatever emotion it might be. And you're saying, "It's fine. I'm here with that. I'm not casting judgment on it." The next statement is respecting. So respecting is turning it around a little bit. So say you've delivered some news, and now you want to look from a strength perspective about what the patient's doing well. So you're going to show a statement of respect might be, let's say a couple has been coping really well together, supporting their family, also supporting one of the partners getting treatment. It's really so impressive how you guys support your family and are still there for each other. You have such a strong marriage or such a strong partnership. And out of the blue, you switch from this point of like being upset or being frustrated to a point of, wow, yeah, thanks for recognizing that. Like that is something that's going well and that we can reflect on as a source of strength. Supporting is all about non-abandonment. So from our point of view, we might have delivered bad news, or maybe we are talking about something difficult, and we're reminding them that no matter what your emotion, no matter what your reaction, what you choose in this difficult medical situation, our team's still going to be here to support you. So I just want you to know that, even though you're deciding to go home to your village, our team's still here for you. We're not going anywhere. We plan on being part of your care team. Or statements along those lines are very helpful in difficult times. When we're talking about difficult emotions, it's important for patients to know that we don't judge them for that, and we're going to still be there for them. So supporting statements are very helpful. And then exploring, as I stated before, is really about diving deeper into the emotion. It's those tell me more statements about what they're going through. Next slide. Spikes. I'll go quickly through spikes because it's really kind of a hidden ask, tell, ask. We use spikes both for holding a family meeting as well as delivering bad news. So setup. So anytime you're going to have a difficult conversation, you really want to make sure the setting is equitable. You want to be in a chair. You want to be at the same level as the patient and the family. You also want all the right people to be there. So who are the right people? Patient gets to define who the right people, and so does the care team. So maybe you need particular specialists, particular doctors, but really the patient needs to also tell you who they need there. Perception. This is the ask. It's one of the two asks. So perception is, what do you understand? Because they're really the expert in their experience and what they understand. So we really need to know that in order to provide them tailored information. Invitation. Would it be okay, having heard your perception, if we give our understanding of things? So that's kind of another ask. Is it okay that we jump right into the knowledge, which is K? And that's where you deliver your information, bit by bit, hopefully in as simplified terms as possible. E, if it's bad news, you pause here. You acknowledge emotion. Use your nurse skills. This is really upsetting. I wish I didn't have to give this news. I wish things were different. Give a moment to process. I think one of the hardest things for most of us to do, even those who have been in a lot of family meetings or delivered bad news frequently in our experience, is this step E. It's sitting with that difficult emotion that inevitably arises from giving the bad news. We want to jump right ahead to what are we going to do about it? What are the things we can fix, or what are the things we can work on? Because that's what we try and do in medicine. Most of the time we're trying to fix. And often when we're giving bad news, it's about things we can't fix or things we tried to fix and aren't getting fixed. So just a reminder that that E is probably the most important thing here. Summarize and strategize. So this is another ask. I'm going to tell you all the things we talked about today. I'm also going to tell you things I heard from you as a patient and family. Does that sound right? And then here's just again for you the steps we talked about doing next. This is a way to be very clear, concise, and sometimes you might even go so far as to give written information for certain families who, in general, being person-centered, patient-centered, and patient and family-centered care, we're often trying to find what's important to people, who they are, what are their values. And in order to get at values, we talk about things that bring them joy. We talk about hopes and worries, and we talk about their support network. Because when we're delivering information and maybe even eventually providing recommendations and discussing strategies, it's hard to do that if we don't actually know who the patient is, what's important to them. In order to devise the right plan, the right recommendations, we really need to know more about them. And so I encourage everyone to ask more questions. These kind of sound a little open-ended and a little, I think, non-specific for people. It might even make people uncomfortable. But you'd be surprised, patients really like talking about these things. They like talking about the joyful aspects of their life. And asking that question really adds a positive element for most encounters, even when you're talking about really difficult things. And then those are points to reflect on later as you continue to build your relationship with them. So other questions, what is your life outside the hospital and clinic? Just a reminder that we have a little tiny snapshot of who this person is. We may be making assumptions or judgments or stereotyping the patient based on what we see and what they said, but if you don't ask them what their life is really like, it's hard to imagine, again, coming up with the best possible plan for them. What is most important to you now is kind of tell me more about what this means to you. So I've told you all of this. Now what is most important for you? And it may surprise you. Again, it may not be that I want treatment or I want this or that medical decision. It may be that I have to go take care of this, or I have important things that have nothing to do with my medical situation, but my medical situation is now affecting them. And what is the hardest part of this for you and your family? So again, asking about the distress that this causes, not only for the patient, but for their entire family. So the last reminder for all of us is that I'm kind of pushing people pretty hard in this talk to put yourself out there, to when you encounter the difficult emotions, when you're delivering the bad news, when you're having these difficult conversations, to dive deeper, to lean into it. And what's hard about it is it's exhausting. It is difficult. It's really emotionally upsetting. Sometimes we even reflect on the personal experiences that we've had in our own lives, and we can be triggered at any time by the suffering and the loss that we're all witness to. And so, I encourage everyone to try and be self-aware. It's the first step of self-care, just to know that you're having a difficult time. Try and practice with teams of people that you can talk to about these difficult situations, and know that, if you are starting to get overwhelmed, having symptoms of compassion, fatigue, and burnout, it can actually change your reactions to your friends, your spouse, your children, and future patient encounters. So it's important for our whole lives.
The bold slide.
Right.
Thank you, Sean. That was awesome. I'd like to open it up to the group to see if there's any questions or comments about just difficult conversations or things, if you want to share anything that you've had an experience with and kind of want to dive a little deeper how that could have gone better. This is a good time to do it. I can say one of our nurse practitioners just got back from a palliative care conference. It was oncology, nurse practitioners, and palliative care. And so, of course, oncology and palliative care go hand in hand. And she as a person, just kind of gets overwhelmed with the acronym. She can't remember them. And so she heard it was I wish, I worry, and I wonder. And those were three kind of things to bring out as part of the conversation. Wishing that we would have better news, or I wish that you would get better, or I wish this would be different for you. But I worry that potentially is not going to happen. I worry that if we don't talk about this now, we're not going to have time to talk about it. And I wonder if it would be okay to talk about this, or I wonder what would be important to you if your health was to get worse. So you don't always need to pick that scab, but you should kind of just plant those seeds. Great job, plant those seeds so that we can kind of move forward as we get a little bit deeper into somebody who's struggling with a serious illness.
Yeah, and you bring up a really good point. The I wish statements are really helpful. I think a lot of people struggle when patients express hopes, or maybe even hopes for a miracle that they think are unrealistic, and they think it's really important to reinforce the medical information. They're challenged by that, but that's impossible. Like, they don't understand, or they're not looking at it face to face. And so you can say something that more general, like, I wish circumstances were different. It's reiterating. That's very clearly saying it's not going to happen, but I'm aligning with you that if it could happen, I would be so thrilled there'd be nothing better in the world than if what you're hoping for would happen. So I wish statements are a really strong way of saying, unfortunately, there's nothing we can do about this terrible situation, and I'm still here with you.
Right.
Versus I hope, where I hope allows a little bit of possibility. So say you're really not sure that something isn't possible, or there's just a slim chance that the patient's hopes are realized. It's okay to align with that hope if you're comfortable with it. It's even okay to align with the hope for miracles, given a miracle is a belief that only divine intervention is going to save things. It's itself like a reasonable hope if a patient has good prognostic awareness. That's all that's going to be helpful. So those are great tools. And then I wonder, is that gentle way of asking permission or hinting at things, kind of being more indirect, less threatening, and allowing the patient to push you back if they're uncomfortable talking about them.
Yeah, I think the beauty of palliative care is it is proactive discussion, and so oftentimes, patients know when they're sick. They oftentimes know when they're dying. They don't want to maybe talk about it. Family members as well. Sometimes what can be helpful for me, if it's worked in the past, is giving patients or family members those subtle signs to say that these are some signs that we would see or that we're hopeful for that would really be favorable, thinking that things are going to get better for you. And these are some signs that if we keep seeing, a downtrend in your cell count or, like whatever it is, that you can let them know that that's not necessarily favorable. And sometimes it's not a cell count. Maybe it's something at home, like, they're spending more time in bed. They're not eating as much. They're weaker. They're needing a wheelchair to move around. They're losing more weight. Something that's tangible for them, even as a layperson, to kind of identify that it's not going well. That's kind of a warning shot that can be really powerful if somebody's not ready to talk about that yet. Okay, yay!
Oh, Vicki?
Vicki! Hold on. We can see her mouth moving.
Just one. I'll talk to you this on the side, Sean, but a patient that all of a sudden we've done everything we can do, and this is the last thing we're going to do, and you offer that information to the family, and you're going with them for a couple days, then all of a sudden it switches, and now we're back on, everything is on the table, and you feel like I've just been deceived, and you're like you've given the wrong information, and it's like you're doing with what you have, but then the situation switches. Yeah,
I think it's one to acknowledge it's really, well, two things. One is extremely difficult being a supportive service and not being the primary service, because we are relying on lots of other people's points of view as the authoritative opinion on a situation. So it is difficult when we are reinforcing medical illness understanding based on one person's point of view, and then a new specialist or a new expert comes in and provides a different point of view. It's also incredibly frustrating to families. And I guess the best way to talk about it is to bring it out into the open with the family. Is to say, how amazing. We talked about this last week, and this was our understanding of what was going on. That was our best understanding. And this week we're hearing that maybe things are a little bit different. How has that been for you guys? What a roller coaster ride. Trying to get at the emotional experience that it might have been. Maybe they're excited about it, or maybe they're really upset about it. It can go either way. It also just, it is kind of part of all care. Unfortunately, there is some subjective elements of assessment. And when you talk about, who's a candidate for some of the most advanced treatments and therapies, there's definitely a subjective assessment. In oncology, it's often the performance status, how fit and independent is somebody. And then in other settings, it might be some of their behavioral aspects. Are they engaging with care? Are they have a history of substance abuse? Do they have the right family support? When you talk about access to things like advanced heart failure therapies or organs. So those things have a lot of subjective assessment. If you get a different assessor, it could really change. But I would encourage you to talk about in the open about, wow, I told you those things, and that was my best understanding. And I hope, you know, even exploring their level of trust in the medical system and in you, because I think, you know, that feels bad to be the person reinforcing that when then the situation changes.
Well, that was juicy. Thank you. I always love talking about communication because we're always learning. Even when we think we're okay at it, stuff can go south really quickly. So it's awesome to have these reminders. Thank you, Sean. I'm going to ask Amy to introduce our group today. If you would start with that, Amy, that'd be great.